Welcome to another lecture by MedicoMedics, Learning Made Easy, Anatomy, Chapter 4, the Cardiovascular System. In this lecture, we will discuss the components of the cardiovascular system, describe the anatomy of the heart, mention blood circulation pathways, what are blood vessels, the composition of blood, mention the cardiac cycle, concepts like blood pressure, the cardiovascular diseases, most relevant to us, its clinical relevance, and end with a summary. Now let's begin with the components of the cardiovascular system, starting with the cardia itself, meaning the heart. Now the heart is the pump that drives blood circulation. We have blood vessels, and these are categorized as arteries, which carry blood away from the heart. We have veins, which mainly return blood to the heart. And then we have capillaries that facilitate exchange of gases and nutrients. Furthermore, another important component is, of course, blood itself. Now, blood transports oxygen, nutrients, hormones, and waste products, and our cells, etc., etc. Now let's start with the anatomy of the heart. The heart is made of 4 chambers. We have the right atrium and right ventricle. We also have the left atrium and the left ventricle. So in this image here, you can see the atria here and here. And you can see the ventricles here and here. Let's change the color on that one. Right here and right here. Now the right atrium and the right ventricle are the part of the heart where we receive deoxygenated blood. So blood has left our heart, entered our body, and is now returning through our veins back to our heart. Why is it doing that? Because from the heart, once it's returning, it is then pumped into our lungs. And when blood is returning, it's coming back through veins, and this blood is deoxygenated. Because once it's left the heart and it's traveling to all the compartments of our body, it's delivering to whatever place it's going. It's delivering those nutrients and oxygen, etc., that our body needs. We also call it perfusion. It's perfusing our organs, etc., etc. Now, once it has done that, it is now deoxygenated. So it needs now to return back to the heart. But that's not the end goal. The end goal of returning back to the heart is to then be pumped out to the lungs. We have a left lung and we have a right lung, right? Now in the lung, this blood then enters into capillaries where there is exchange of carbon dioxide leaving our body and oxygen exchange, leading to this blood becoming oxygenated again. Once it's oxygenated again, it is then pumped into the left atrium as oxygenated blood. That's why we say left atrium and the left ventricle pump oxygenated blood. That's the basic overview. Now, that's the 4 chambers. So that's the 4 rooms of the heart. Then we have something called valves. And we have the atrioventricular valves, which encompass or include the tricuspid valve and the mitral valve. And we have the semilunar valves, which include the pulmonary valve and the aortic valve. Now, one valve is right here from the right atrium, right, the first room. Blood is being pumped to the right ventricle. And valves are like doors that open and close. When it's opened, this blood is being pushed into that right ventricle. Furthermore, once it's arrived at the right atrium, it then continues, as we said, into the lungs for oxygenation, right? Because it's deoxygenated blood right now. When it does that, it passes another valve or another door. And that door is the pulmonary valve. Once the blood is oxygenated in the lungs and is now returning back to the heart to get pumped out into circulation, it enters the left atrium, right? And between the left atrium and the left ventricle, we have another valve called the mitral valve. And from the left ventricle, once blood is ready to get pushed out or pumped out to our body, it goes through another valve called the aortic valve. So it's 4 valves in total. Now you notice that they are grouped. Like we have the atrioventricular valves, the tricuspid and the mitral, the semilunar, pulmonary, and aortic. So you may wonder, why are they grouped? Well, it's because these two open and shut simultaneously. And the same is true for the pulmonary and the aortic. So when the tricuspid valve from the right atrium, where deoxygenated blood has arrived, right, through the big veins, the superior vena cava, and from the lower extremities, the inferior vena cava. Now, when the blood is in the right atrium and is going to get pumped into the right ventricle, we said the tricuspid valve opens. But when it opens, the mitral valve, which was the door between the left atrium and the left ventricle, also opens. So these two open at the same time. So as deoxygenated blood is getting pushed into the right ventricle, to then get pumped into the lungs, while that is happening, oxygenated blood is coming from the lungs into the left atrium. And then they close. Once they close, the blood now from the right ventricle needs to go to the lungs. So the semilunar valves open. The pulmonary valve, so blood from the right ventricle can go to the lungs, and the blood in the left ventricle can get pumped out into circulation. So the aortic valve needs to open. And here is just a little thing which gives it clinical relevance here. When you go to the doctor and the doctor is listening with a stethoscope, right? You've seen probably a stethoscope that they place on your chest to listen to your heart. What that doctor is listening to is the closing and opening of those valves. That's the very basic. And why are we listening to these doors opening and closing? Because there are pathologies, there are diseases where these different doors encounter problems. They can become rigid, or they can, you can develop scarring and damage to them. And if you do, well, then you can imagine that this door will close poorly or barely close. And if it doesn't close, what could happen then? Well, if a door is semi-open, pressure from one room will push some blood into the other room. And it's not supposed to do that right now. The door is supposed to normally get closed, let's say. And when we listen to the heart, we can capture that the door is not closing properly. But normally, we're listening to the opening and closing of, actually, we're listening to the closing of the tricuspid and mitral valve, and then of the pulmonary and aortic valve. Anyway, so we mentioned the 4 chambers. We mentioned valves or doors. We then have the layers of the heart. We have the endocardium, which is the inner lining. If you look here, you can see that we have the endocardium, which is the inner lining. We have the myocardium, which is the muscular layer, the thick muscular layer. And then we have the pericardium, which is the protective outer layer. Now, this was a vast but fundamental overview. All these different parts will be repeated as you go throughout the lecture series. Now, let's move on to blood circulation pathway. So, we have pulmonary circulation, where deoxygenated blood flows from the right ventricle to the lungs through the pulmonary arteries. And we have oxygenated blood returning to the left atrium via the pulmonary veins. And this is precisely what we just went through in the previous slide. So deoxygenated blood returning to the right ventricle, going to the right atrium first, then going to the right ventricle. And then it's being pumped to your lungs to become oxygenated, right? And this is happening through the pulmonary arteries. And we said as that is happening, we also have oxygenated blood from, let's say, the previous pump returning to the left atrium. And this is returning through the pulmonary veins. Now, we also have systemic circulation. So oxygenated blood is pumped from the left ventricle to the body through the aorta. So this is your aorta. And if you remember, the door between the left ventricle and the aorta is the aortic valve. So when it opens, there is a contraction of this muscle. Left ventricle contracts, and that blood is pushed out to go into circulation. And as that is happening, again, deoxygenated blood returns to the right atrium from the superior vena cava and the inferior vena cava. So you're hopefully starting to see that the heart is actually behaving like a double pump. It's doing 2 things simultaneously. It's filling as it's pushing. And that's what makes this organ so fascinating. Now then, moving to blood vessels. So we mentioned 3 important vessels here. We have the arteries, and we have the veins and the capillaries. Now they are all distinct from one another. So the arteries have thick muscular walls, and they carry blood under high pressure. So it kind of makes sense that they should have thick walls, right? So you've probably heard in movies or on the TV that be careful if they get cut in their artery. Why? Because blood will spurt out and you will bleed very fast. And the reason for that is the blood flowing through it has a high pressure. So if there is an opening, that blood will pop out. Then we have the veins. So these have thinner walls with valves to prevent backflow. So if we have a vein here where blood is perhaps indeed returning back to the heart, this deoxygenated blood is carried with a lower pressure. So if you get, let's say you get stabbed in a vein, that blood will not spurt out like it would if it was in an artery. Why is that? Because the pressure here is far lower. We also mentioned that there are valves here in our veins. And these are to ensure that the blood slowly moving upwards does not flow back to accumulate anywhere. Then we have the capillaries. These have thin walls for gas and nutrient exchange. So as the artery, that could be imagined to be a big tunnel, is moving towards perfusing your body with oxygenated blood, this big road or tunnel is then turned into smaller tunnels, right? And then these continue. So we have arteries, these become arterioles, and then they become capillaries. And these capillaries have such a thin wall, it will allow for gas and nutrient exchange to occur. So whatever it is supposed to deliver, since it is our blood that is carrying all the nutrients and the cells, etc., that we need to be delivered to some part of the body. It then picks up the waste products, and this deoxygenated blood is then circulating back through veins that will pick it up and then move it back into the heart for another round of oxygenation. Now that's how it's supposed to be working. So the blood composition then. Blood is composed of plasma, which is the liquid component making up about 55% of blood volume. Then we have red blood cells, erythrocytes. These carry oxygen via hemoglobin. Furthermore, we have white blood cells, or leukocytes. These are involved in defending against infection. We have platelets, or thrombocytes, that are crucial and important in clotting and coagulation. Now here's a little clinical note. Blood disorders like anemia or leukemia can affect these components. Now the only thing you need to keep in mind here is, number one, remember that the blood is composed of several things. What are those things? Well, everything we study in med school, like blood plasma, red blood cells, white blood cells, platelets, etc. What are all these things, different cells doing? Well, platelets, for example, our thrombocytes, like we mentioned, is important in coagulation. So if we have arteries, right, we have arteries, maybe there will be a tear somewhere, and there will be an internal bleeding happening. Our blood is composed of platelets involved in stopping that bleeding and forming a clot to coagulate and stop this bleeding. Now you can probably imagine that what if it clots too much? What if the coagulation cascade, as it's known as, gets out of control? What if we have some disorder, let's say, where blood is not clotting? So you have a little bleed somewhere, either an external trauma to you or an internal tear in one of your capillaries or your veins or arteries, etc. If you have a reduction of platelets, or if you have a problem with the coagulation process happening, meaning clotting to occur, maybe it won't stop this bleeding and you will bleed out from very superficial wounds, let's say. Well, actually, we have a name for that. It's hemophilia, for example. What about a patient who has an infection and he comes to your office? What do we test? Well, we will look at his white blood cells, his leukocytes. Why? Well, if they are elevated, we will know that, oh, his body has an elevated level of leukocytes activated. It means he's probably fighting off an infection. Or we may see that, oh, he has an extremely low count of several cells. Well, we know that if we have a patient with a type of cancer, these cells could perhaps not be developed as they're supposed to. So we see a reduction in a lot of these cells, which could lead us to consider cancer, for example. So all of this is extremely relevant to the day you are in your office and your patient enters the room. And so we will study all of these in detail, especially in hematology, for example, where we study blood. Now then, the cardiac cycle. Now this could be a complicated part of the lecture, but what I want to leave you with, if anything, is that you learn by the end of this lecture that you can never, in your future, as a medical doctor, think about the heart as solely a mechanical system. Because we mentioned before, we said that the heart was made of these 4 chambers, and that these doors of the valves opened and blood went through, and then the muscle contracts and blood is ejected into your circulation, etc. And we can look at this. We can see this pumping occurring. And so we see this mechanical system pumping and contracting and relaxing, etc. But what you will learn, or what you maybe already know, is that there is also an electrical component to the heart. So if you think about what we just said, we said that the blood is pumped from the right atrium to the right ventricle. And then there is, for example, later a contraction of the left ventricle pumping the blood out. But how is these things contracting? How are these muscles contracting? And why is it happening in this way? Why is it such a stepwise system where the atria are contracting and the other parts are relaxing, etc., etc.? And when we talk about the cardiac cycle, we talk about 2 main things. One is systole, the other one is diastole. So when we say in the cardiac cycle, when we're talking about systole, we're talking about the contraction phase. So blood ejected from the heart, meaning the left ventricle is contracted and the blood is now leaving. Then we have diastole, which is the relaxation phase. So now the heart is relaxing and filling with blood. But as we mentioned before, while one part is filling and blood has left, other side of the heart, the other chambers are also involved in the same process. Now, when we talk about the electrical conduction system, we have the SA node, sinoatrial node. We have the atrioventricular node, the AV node. We have the bundle of His, and we have the Purkinje fibers. These are the main structures you need to remember. And this is involved in controlling the heartbeat. And when we have a normal rhythm, we call it having sinus rhythm. So what's happening is that the SA node starts off sending a signal. That signal tells the atrias, right? The atrias to contract. And so this is also why we call by the way, the SA node is also called the pacemaker, right? And it's located indeed in the right atrium. Now, this generates that electrical signal that sets the heart's rhythm. And during that time, while it's spreading through the walls, as you can see, through the walls of both the atria, so the left and the right, it causes them to contract. And when the right atrium and the left atrium contracts, what happens? If you have blood here, that blood will then get pushed to the ventricles in both sides. What then happens is that that signal from the SA node reaches the AV node. And the AV node is located between the atria and the ventricles. Now, the AV node briefly delays the signal to allow these ventricles, right, where blood has now been pushed, time to fill with blood. So to give it some space and time to fill with blood, the AV node sort of pauses the signal to continue further on. And then what happens next? Well, after the AV node, the electrical signal then travels down something called the bundle of His. It's a pathway in the septum, which means in the wall. It's in the wall between the left and the right ventricles. Now, this bundle that goes through this wall here in the septum then splits into two different branches, as you can see here. One goes to the right ventricle and one goes to the left ventricle. Now, by the way, do not be confused when I'm drawing and saying the left ventricle. Your eyes are probably seeing me drawing to the right. But if you always remember from the beginning, we said the anatomical position. So you have to imagine this picture is a heart on a patient who is facing me. So it's the left side for him while I'm drawing it on my right side. Always keep that in mind. So while the signal is indeed continuing to travel, the ventricles have not yet contracted. So they're still preparing. Now what happens next is that we reach the final stage, which is when the signal reaches the Purkinje fibers. That's the final stretch. So what happens is that the electrical signal moves from the bundle of His, right? The bundle of His into the Purkinje fibers, and this will lead to the spread throughout the walls of both ventricles. And these fibers distribute the signal very, very quickly, ensuring that both ventricles contract simultaneously. So as the ventricles contract, blood is being pumped. So the right ventricle, like we mentioned, pumps the blood into lungs, and the left ventricle pumps the blood to the rest of the body. So let's summarize again. First, the atria contract. So the SA node fires, pushing blood into the ventricles. Then we have the ventricles contracting. So signals move through the AV node, where there is a brief delay, giving it time for the ventricles to fill. Then it travels through the bundle of His to the Purkinje fibers, leading to ejecting blood to the lungs and the body. Now, another very important part of all of this, which is blood pressure. So blood pressure is the force of blood against vessel walls. We measure it as systolic pressure and diastolic pressure. Just in the previous lecture, we mentioned systole and diastole. So systolic pressure is the pressure during the heart's contraction phase. So when the heart is contracting and blood is being pumped out, we ask ourselves the question, what is the pressure? And whatever value we get, we will say that, oh, the pressure with which the heart is pumping out blood in this individual is this level. And the other question we ask is, well, once that contraction has occurred, and now the heart is going into relaxation to become to fill up. What is the pressure then? And whatever that value is, we call that the diastolic pressure. So we measure two things: the pressure during contraction and the pressure during relaxation. And in a normal blood pressure, this is the number you have probably very often heard about, which is the number 120/80. And we measure this pressure in millimeter mercury. Now, why is this clinically relevant to us? Well, if you have hypertension or hypotension, you will have significant clinical implications following from that. So if you have a patient who has 180 systolic pressure, that pressure is extremely high to be traveling through your circulation. And vice versa. Imagine you have 80 systolic. That is way too off to be delivering. Why is it off? Well, it's because, like we said, blood is being pumped out from your heart to arrive at whatever parts of the body that needs nutrients and oxygen. If that pressure is too low, it will not be able to meet all these or make all these deliveries, which means, in medical terms, our body is not being perfused, or our organs are not perfused. And if oxygen and nutrients are not arriving to this said organ, what will happen? Can it survive without oxygen, without its nutrients? No. Now then, let's briefly mention some cardiovascular diseases. We have coronary artery disease, or we have a blockage of coronary arteries. What are coronary arteries? Well, remember, we talked about the heart, right? And it's easy to forget that while the heart, primarily indeed, we talk about it as a pump taking blood out of the heart to be delivered to our body, to our organs, and simultaneously deoxygenated blood returning to the heart to go to the lungs. We also need to keep in mind that this is itself an organ. The heart itself needs supply. So if it is supplying the rest of the body, how is it supplying blood to itself? Well, this is where we talk about coronary arteries. These are arteries that are supplying the heart itself. And we will, in the future, go through in more detail that where it does blood enter into the coronary arteries. We have proximate to the aortic valve. We have the structure of the trunk. And that trunk, just before we enter into the aorta, we have arteries going backwards, dividing into left artery and right artery and circumvent artery, etc., etc. That's not important for you to remember right now, unless you're interested to go study those coronary arteries. What we want you to remember right now is that the heart not only provides blood to the heart, to the rest of the body, but also to itself. Another thing is heart attack or myocardial infarction. This is death of heart tissue due to ischemia. So as we mentioned in the previous picture, what happens if the blood pressure was so low that whatever organs, let's say, that are supposed to be receiving nutrients and oxygen do not, because of, indeed, in this example, let's say low blood pressure, poor blood pressure. So this thing here is not receiving this necessary oxygen. Well, what will happen? It will go through ischemia. This tissue will slowly start to deteriorate and die. And when it dies and becomes ischemic, imagine that is happening in the heart muscle itself. So let's give it some context in relation to the coronary artery disease. So let's say one of those arteries that is supposed to supply the left ventricle, let's say, has become occluded for whatever reason. So there is a blockage in that coronary artery. So the blood supply to this part of the heart is stopped. Well, this part of the heart will start to become ischemic and die. Well, let's say we have 100% function in our left ventricle. This part consists of, let's say, 30%. Well, if it dies off, you will have 70% left. And there is a chance that 70% is not enough for the ventricle to pump out the necessary amount of blood in its next contraction to perfuse your body. So you see the cycle here. Now anyway, so coronary artery disease, blockage of coronary arteries, heart attack, myocardial infarction, so death of heart tissue due to ischemia. We mentioned hypertension already, so chronically high blood pressure. Heart failure, so the inability of the heart to pump effectively. So if you have a heart attack, and as I just illustrated, parts of the heart break down and die, the muscles, you will have an inability to pump effectively. So your heart is going into failure or is failing. Another one is arrhythmias, abnormal heart rhythms. If you can connect it now to the previous slides where we talked about the conduction pathway, like I mentioned, whatever we're talking about right now in this slide, the things I've mentioned, like the blood being blocked and not arriving at the heart wall, leading to death of tissue, we can call this the mechanical view of the heart. Because this is very mechanical, it's physiological. You can see that blood, that tunnel, it's blocked, whatever. What we don't see in this case is the electrical conduction system, right? The SA node, the AV node, as we mentioned, the Purkinje fibers, etc., that are relaying these signals to create this contraction. Now, with the conduction pathway, with these electrical systems, we have a whole set of other problems that could happen. Since the SA node determines the rhythm of the heart and therefore the rhythm of the heart in general, imagine if the electrical system itself breaks down or isn't functioning the way it's supposed to. Now, you will learn as we move along in our lecture series and in the course on cardiology more specifically, when we talk about the electrical system, we're talking about ions and cations like sodium, like potassium, calcium, etc. These different ions and cations need to enter into the heart cell at different points to create what we call depolarization. And then repolarization is supposed to occur. That's directly mirroring what we call this mechanical contraction. So these two things are two sides of the same coin. And if you have too much of potassium in the cell, or too low, or too much of that, or too little of calcium coming in, etc., this will create delays and problems of the contraction. Or if signals are not being fired the way they're supposed to, or there are damages to these different nodes, or whatever, we can have things like atrial fibrillation or ventricular tachycardia, etc., etc. All of these we call arrhythmias. And then we have stroke, caused by blockage or rupture of cerebral blood cells. So, if you're going to take anything with you here, it's to remember that the heart has both this mechanical side to it, but it simultaneously has this electrical side to it. So you think about both simultaneously. You can apply the same thing when thinking about the heart as a pump. It both fills and pumps simultaneously. So it's a very fascinating structure an organ to study. But if you just look at one side of it, you will become blind to the other. So it's important to keep this elevated view of the heart constantly. And when you learn, now we just mentioned quite a few um, possible pathologies or diseases, etc. But I hope it was enough to illustrate that because there are so many parts to it. The muscle walls itself. Previously, we mentioned that there are layers to the heart, like the pericardium, the outer protective layer. You will come to learn that the pericardium has something called a pericardial fluid, which is there to lubricate around the wall of the heart. It can become inflamed, leading to something called pericarditis. You have layers of the heart, like the myocardium. You can get infections like myocarditis. We can have a heart attack, death of this heart muscle tissue. We can, for whatever reason, develop hypertension, putting strains on arteries throughout the body, potentially leading over time to a stroke because it's too much pressure on these blood vessels. We have all of these tunnels, right? We have arteries everywhere supplying blood to our body. They can become occluded. It's a tunnel. And we mentioned, for example, before, clotting, right? In our blood, traveling in our blood, we have thrombocytes, platelets, that are supposed to stop bleeding here and there. Imagine it overworks itself for whatever reason, or there is damage and tears in your blood, and it's leading to the buildup of a potential blockage. And then you will come to learn that when there is a blockage, if you imagine a tunnel and you have a buildup of blockage here, first of all, indeed, less blood will be arriving at whatever system is waiting for it, right? But what will also happen is that the blood that is coming here wants to push through. It wants to push through because it's necessary to get that blood to this organ or to this place. So how will the heart compensate with this blockage? Because this blockage increases the resistance of this tunnel. Luckily, we have systems in check and in place, so the heart recognizes somehow that, okay, there is a block in my system, I need to push harder. So the heart does what? It elevates its blood pressure. So you get hypertension. And if this occurs over time, what happens to the heart? If the heart is pumping harder, it's a muscle, right? And if it's a muscle and you pump that muscle, you're going to grow that muscle. And as that muscle grows, it becomes awkwardly big in a certain way. Now we have to deal with the problem of, wait a minute, will it function the same way? If this muscle increases in growth, will it fill as it's supposed to? Will the blood pump out? Will it contract as it's supposed to when it's too big? No. And we have even a disease called hypertrophic cardiomyopathy. Essentially, you have a left ventricular hypertrophy. So all these intrinsic details are correlated with different diseases. That's why it's so important to have a clear idea at the very beginning so that you are ready for all those details when they come as you progress in your studies. So, clinical relevance. Well, we use diagnostic tools, right? We use the EKG, electrocardiogram, to measure the electrical activity. Now you should know what is it the doctor is testing for. Well, we're looking at the electrical conduction pathway, if it's working as it's supposed to, if the mechanical view, so if the valves are opening and closing as they're supposed to, Is contraction happening the way it's supposed to in correlation with your electrical system? And any abnormality will show on an EKG. For example, if a signal goes too quickly or stays too long at the AV node, for example, we will see, if you've seen an EKG. Now, this is just a brief illustration, but you can see that QRS wave, as it's called, right? What we look at is this line too long? Is this QRS complex is it looking normal? Is this wave too deep? Do we have, so this wave, the ST wave, let's say it, instead of going down here as it's supposed to, it actually goes like this and it elevates. What does that mean? This means something in the mechanical side of the heart. If this line here between the P wave is too long, this will indicate something happening here. So these two things are different sides of the same coin. The electrical side of it all and the mechanical. The sooner you grasp that and have a clear idea in your mind, the faster you will progress in understanding medicine in general. We also have echocardiograms, where we are looking for heart structure and its functions. We have angiography to image blood vessels. We have a vast range of different medications when we treat. For example, we have antihypertensives. Why? Because we just mentioned hypertension is a problem. We have anticoagulants. Why? Because we mentioned too much coagulation can block arteries. We have surgical interventions like placing stents, doing bypass surgery, etc. In the course on cardiology, we will delve much more into detail, but here is just to give you a brief overview. So then, in summary, the cardiovascular system is essential for transporting oxygen, nutrients, and waste. The heart, the blood vessels, and the blood components work in tandem. Pulmonary and systemic circuits ensure oxygen delivery and waste removal. Understanding cardiovascular disorders is critical for clinical practice. Yes, indeed. And that's the end of Chapter 4. Continue now to Chapter 5.